Hi everyone. My name's Holden. I'm a fifth year medic here at Oxford. And the topic for tonight's lecture is hypertension and heart failure. So before we get started, I just wanted to mention a few things. The way I've set out these slides is that they're slightly more word heavy, slightly more note-like, and the intention there is that they can be a useful revision tool for you to go back to. And so hopefully that's useful to you. I've also included in the notes section of the slides snippets from my own notes from second year to give a bit more depth to some of the topics I'm talking about, so that if you want to go back and download the slides, some of the topics make a bit more sense. And as I said, you can use it for revision. So with that said, let's get started. So the topics of hypertension and heart failure are two pretty big topics in both cardiology and just physiology and pharmacology in general. They take up the majority of your preclinical physiology time, and they also take up a good chunk of your clinical general medicine time, because they're pretty common conditions. So the benefit of that is that you get lots of lectures on these topics. So this will not be your first, nor will it be your last lecture on these. But my hope is that by taking you through both topics from a first principles point of view, you can build on your understanding from here and go back to this as sort of a base for your general understanding. So I've divided it into first talking about blood pressure as a physiological topic, so regulation of blood pressure in both the short and long term, to then give us a platform to build on for talking about the pathophysiology of hypertension, and then we'll talk a bit about the medications. Similarly, for heart failure, I've divided it into a short-term and long-term cardiovascular failure, and we'll spend more time talking about the long-term variant, thinking particularly about the classification and the pathophysiological mechanisms, and then also the treatment. And there's a bit of overlap with the treatment with hypertension, so hopefully by then you'll be able to kind of think about what mechanisms are important. Along the way, I've included points from the syllabus indicated with the symbols at the bottom, hopefully help you follow along if that's what you want to do. Also, if you don't want to look at the syllabus, then this is relevant for you. So if we start off with the short term, and what I mean by that when we're talking about blood pressure regulation is sort of minute to minute regulation of blood pressure. And that is a closed system, so we don't consider inputs or outputs because it's so short a period of time. So broadly, the function of the cardiovascular system is to provide adequate circulation of blood and therefore oxygen to tissues. And this requires a broadly constant blood pressure. And I say broadly because this is a systemic blood pressure that needs to stay the same. At a tissue level, blood pressure can change minute to minute based on metabolic requirements, and it will do. But the whole system, on average, needs to maintain blood pressure to keep your heart, lungs, and brain well perfused at all times. So what I've done is drawn a diagram on the right of the baroreceptor negative feedback loop, which is the short-term regulating system for blood pressure. And in the notes section, I've written out in much more depth what all of these structures are and what they do. But for simplicity's sake, this system is made up of baroreceptors in your carotid body's aortic arch, and these are stretch-sensitive receptors embedded in the walls of the arteries, which detect changes in mean arterial pressure as stretch in the vessel. So as pressure goes up, there's more stretch, and then for more signal into this closed loop system. And the output of this system is via the sympathetic nervous system, and on the diagram we'll use a pointer via the sympathetic efferents and via the sympathetic chain, you have control over cardiac output. So that's contractility, sort of chronotropy and inotropy, which is speed and strength of contractions. And then you also have control of vascular tone. And if we think of mean arterial pressure as the product of cardiac output and total peripheral resistance, short-term changes in these two outputs will feed back into a change in mean arterial pressure and therefore close that loop. And then at the bottom here, I've just given you the two instances, either increased stretch from increased pressure, leading to increased medullary neural activity, so in the brainstem here, which inhibits sympathetic efferents and therefore reduces the sympathetic tone of the system, and vice versa. If blood pressure falls, say if you stand up suddenly, blood pressure will fall across the system acutely as gravity acts on your blood. You'll need a rise in sympathetic nervous system activity to counteract this. So that's the short term. In the long term, the difference is we're talking days, hours, years, long time. And therefore, we need to consider inputs and outputs, which were excluded in the short term. Inputs are largely from the gut, and outputs are primarily from the kidneys, although I guess you have sweat and sort of expiratory moisture as well. But the kidneys are the ones which are most important and deal with the majority of your excretion of fluid. Now, some would argue that the long-term blood pressure regulation is the same as your short-term. It's just an extension of it. And by that, I mean your sympathetic tone, controlling your cardiac output, and your vascular tone are the most important factors. Others would argue that fluid and sodium are much more important regulators of long-term blood pressure. And it's that group of people, which we will sort of follow with today, thinking about the Guyton model, which is what you get taught at Oxford. And you'll all have seen before in lectures. And it's worth pointing out that this model is not it's not 100% accepted across the field. And that's partially because we don't have a perfect model of blood pressure regulation. It's such a complex system that we can only guess at how it works. Sort of the phrase, all models are wrong, but some are useful. It's important to think about here. This is just one model, one way of representing long-term blood pressure. And there are critics of it, and there are papers out there which say it's completely wrong. But there are also others which say that this is the only method. So if you ever find yourself getting confused or finding holes in the model, which are, it's entirely possible and entirely likely that that will happen. And that's just because it's a model, it's imperfect. So I find it's best explained by the review by Dorrington and Pandit to Oxford academics and clinicians in 2009, and they draw upon this idea of fluid balance. So we'll talk about the diagram on the right, which is a diagrammatic representation of Guyton's model. And you'll have seen it in lectures before, but I'll just quickly explain it to you again. You have the heart and lungs modeled by this circular pump here with an output of Q. You have the total vascular resistance, the average of all peripheral resistance as R. And then you have a venous circulation and an arterial circulation with reservoirs indicated by these cylindrical columns. And the height of fluid in each column represents the pressure in the system via the formula rho GH. So as you'll remember from physics in high school, height of fluids is equivalent or is proportionate to its pressure at the bottom of the system. And then the cross-sectional area represents the compliance of each system. So veins are more stretchy, more compliant. And therefore, as fluid fills the venous system, you don't get as steep a rise in pressure and so you don't get a steeper rise in height here. Whereas in the arterial system, because the vasculature is tight and muscular, a small rise in fluid leads to a much greater increase in pressure, and in this diagram, height. So if we continue this model forwards, you'll see these curves on the right, which are drawn to sort of graphically depict what's going on and the relationship between Q, cardiac output, and pressure, both venous, PV, and arterial, PA, on the x-axis. So I'll just break it down for you quickly. The venous pressure line is this line here, and this represents the fluid in the venous system, fairly obvious. And if you think about it, as cardiac output increases, so you move up this line, you get a reduction in venous volume. More blood is pushed across into the arterial system, so you come down the PV, down the pressure in the system. So that's how you get that shape. Next, you have the Starling curve, which you'll see lots in cardiology. And this basically shows that as preload in the heart increases, preload being the blood that fills the heart before contraction, which is a function of the pressure in the venous system. So more pressure in the venous system leads to more preload, which stretches the cardiomyocyte more, and therefore means that their contractile force is greater. So you get this upward sloping effect. And then you have the arterial pressure line, which is the inverse of the venous line, because as cardiac output increases, as we spoke about, come down this curve, more blood is moved across into the arterial system, so you ascend this arterial line. And the equilibrium that results is this Q1 point. So we'll talk a little bit later about how shifts in these lines occur and how we can use those shifts to think about what happens to blood pressure in the long term. Right. Final step of this model is finally taking into consideration the kidneys. So if you think back to 2 slides ago where I showed you that, actually I'll just show you this diagram with a column of arterial fluid. You have these holes towards the top of the column, which represent the kidney as the point of fluid excretion. So in order for the body to maintain that same principle of constant average blood pressure in the long term, which is what we're aiming for, you need to make sure that the fluid in equals the fluid out, roughly speaking. The body does this by increasing the rate of fluid excretion in line with an increase in arterial pressure. It's not quite equivalent, because we can see this curve here. It's an extremely steep relationship. If you imagine, as your arterial pressure increases, because you've taken on more fluid, and that adds fluid to your circulating volume, you push yourself up this urine sodium excretion curve, massively increasing the amount of fluid excretion you get. And that holds you at this physiological tight line here of blood pressure. So it's difficult to go lower or higher based on pressure natriuresis. And as I said here, in healthy subjects, the curve is sort of centered around a normal sodium intake. And you get here a little peek into the pathophysiology of hypertension, which we'll talk about more later. But something in the pathophysiology, maybe one of these blue points here, changes the slope of the curve and therefore the relationship between arterial pressure and sodium excretion. So you somehow interfere with pressure natriuresis. This slightly blurry diagram in the bottom right summarizes a couple of the factors which alter this end relationship between renal perfusion pressure, which is a function of blood pressure, and sodium excretion. And so we'll talk about those in a bit more depth now. And as I said, if hypertension changes the relationship between pressure and sodium excretion, or fluid and sodium excretion, we can therefore kind of extrapolate that hypertension is a disease of the kidney, amongst other things, because kidney is the key to that relationship. So supporters of the Guyton model would argue that we cannot explain long-term blood pressure as just a factor of vasotone and cardiac output. And they would do so by referring to this diagram. This diagram basically proves why you need to think about the kidneys. And I'll talk you through it quickly, as it's just a good way of centering yourself and remind yourself why perhaps this model explains things that other models don't. So we start at point, we start at point 1, Q1 on the diagram. Now, if you apply a vasodilator to this system, you first move to point 2, Q2, point 2. And that's because you change the slope of both the venous pressure curve on the left and the arterial pressure curve on the right. Because vasodilation changes the volume that both curves can, that both arterial and venous systems can hold on to, and therefore changes the slope, the relationship between cardiac output and pressure. And the formulas in this Dorrington and Panda paper kind of show you why the gradient changes. So it's useful looking at that. So you've therefore caused an acute fall in blood pressure, modeled by point 2, PA2. You're at a lower arterial blood pressure. Your body senses this as a reduced blood flow to the kidney. And because the kidney is hoping to maintain long-term blood pressure, it responds by increasing pressure natriuresis, fluid recall or fluid resorption. You reduce fluid excretion, and suddenly you get an increased MCFP. MCFP is a sort of is equivalent to the total volume in the body, total fluid volume in the body. So you see here, we suddenly move from point 2 to point 3 as the base of these curves move. And point 3 represents the point where you've suddenly got this increased total circulatory fluid volume. And so you've basically moved yourself right back to the same point of arterial blood pressure. Despite applying a vasodilator, you have the same arterial blood pressure, but just at a higher cardiac output, because your body has responded by increasing fluid volume. The implication of this is that antihypertensives cannot just work by vasodilating or changing cardiac output. They must also alter the relationship between arterial pressure and urine output. That's kind of the conclusion of the Guyton model. And this is what we'll take forward when we talk about antihypertensive. So now we've got the model under control. We just want to think lastly about how the body can change the pressure natriuresis relationship over time, because it does change depending on situations and circumstances, environmental circumstances, and that's physiological. So there's 4 listed here, but the most important is the renin-angiotensin-aldosterone system. Again, in the notes section of this lecture, you'll find more notes about the other 3 aspects, but we'll focus just on the RAS system for now. And on the right in this diagram, you can see a summary of how the kidney, through JGL cells mainly, senses changes in circulating volume. And you'll have had lectures on how the kidney's intrinsic mechanisms work like this. It's more complicated than we need to go into for this lecture, but these JGA cells sense a change in blood pressure coming to the kidney, respond by increasing renin release, which sparks off this RAS cascade of angiotensin II production, which leads to vasoconstriction, ADH release and thirst, sodium and water absorption, and also aldosterone, which is the second part of the cascade. And this alters the membrane channel composition of kidney nephrons. In the middle, I've got some experimental evidence. Again, there's more details about this in the comments or in the notes section if you want experimental evidence to help your understanding. But essentially, it's just proof that artificially altering the renin-angiotensin-aldosterone system through adding either artificial angiotensin 2 or inhibiting the ACE enzyme, which converts angiotensin 1 to 2. Either of those two changes will alter the shape of the pressure natriuresis curve. And you can see on the right how it moves the sort of the holes of the kidney in that model. It changes at what point the kidney starts to release or excrete fluid. So hopefully that makes sense. And finally, we're on to talking about hypertension after we've talked about physiology. Hopefully this all now makes a lot more sense when we talk about treatment, because we've got a base understanding in the physiology. So simply put, hypertension is persistently raised arterial blood pressure. Nothing more complicated than that. And it affects a huge proportion of the adult population. So this is a UK specific stat. This is Public Health England. But globally, it's a massive medical comorbidity that you'll see in many patients when you get to clinical years. Risk factors are, some of the risk factors are these written here. There are other risk factors, but these are most important and ones you might think about when stratifying someone's risk of developing hypertension. And why do we care about hypertension? It's because it is a massive risk factor for both stroke and ischemic heart disease. And that's largely because increased pressure within your vascular system leads to increased shear stress on the walls of the vessels. Shear stress is converted to inflammation through some inflammatory cascades, which you might learn about in third year. And that kicks off the start of atherosclerotic development. And therefore you get bigger atherosclerotic plaques forming, which can break off and cause a stroke. And you also get ischemic heart disease. And then this is just about NICE treatment recommendations, more relevant for clinical years. But if you want a nice summary of NICE's approach to hypertension, they have a really clear flow chart, which they use on their website, which I'll show in a second. Crucially, and what we'll talk about mostly on the next slide, is that the pathogenesis from most people's hypertension is kind of unclear. It's not one common process that we can clearly define. So when we talk about hypertension, we either talk about essential, primary hypertension, or secondary. Secondary is kind of easier to describe, so we'll talk about it first. It's hypertension where you can point to a specific fault in the long-term blood pressure regulation system. And that fault is almost always reversible through some sort of treatment, and is the sole source of the entire hypertensive picture. So thinking about kidney disease, either your nephron, your end unit of pressure natriuresis, is faulty for whatever reason, either genetic or can be from autoimmune conditions. You could also have a stenosed renal artery, and that reduces the blood flow to the kidney, makes the kidney think that there's low circulating volume and low blood pressure, and causes it to kickstart an increased pressure natriuresis response. Anything like that. Pheochromocytomas, this is a favorite of endocrinologists, and you'll see maybe one or two on the ward when you get to clinical years, but a tumor releasing extra catecholamines causes increased vasoconstriction, increased renin secretion, and so you can point to that as the problem causing hypertension, reversed through surgical removal of the pheochromocytoma. Things like Cushing syndrome and Conn syndrome, two clear endocrine syndromes. So you have either too much cortisol in Cushing syndrome. Cortisol acts at mineralocorticoid receptors as an agonist. So like aldosterone, increases renal tubular sodium resorption through altering the membrane channels. So that's the problem you can point to. So mineralocorticoid receptor antagonists, for example, might be a good way of treating that. And then con syndrome, you have too much aldosterone. Again, similar mechanism. So fairly clear how those ones work. You can point to a specific point. And actually, if you look at on the right in the diagram, I'm sure you can find, for example, where each of these conditions might fit in to the whole system. But then you have essential hypertension, and this is the majority of people's hypertension. And it's not a single identifiable cause. It's a sort of cascade of complex polygenic components which converge on this end picture of hypertension. And I've referenced here a review which talks about the mosaic theory, which is essentially, it talks about how a constellation of genetic, humoral, endocrine, neural, anatomical, and environmental components all converge to produce hypertension. And one of the ways, and one of the most popular theories as to kind of how this convergence sort of works is that these risk factors precipitate small artery pathology, and you get this positive feedback loop of inflammation in the walls of the arteries causing atherosclerosis, leading to stenosis and inelasticity of the vascular walls, making or leading to more hypertension, which then further worsens the effects of atherosclerosis and further worsens the process, and you get a positive feedback loop. But again, what starts off this this loop is not a clear factor. It would be a complex polygenic condition. And this is only one idea of how it works with the inflammation. There could be other ways in which your polygenic background precipitates hypertension. And so here I've just put a one piece of experimental evidence which contributes to this idea of inflammation being responsible. And crucially, this last point here, they conclude that inflammation precedes the hypertension, and they're looking at CRP, which is an acute phase reactant, which is a marker of inflammation being associated with increased hypertension in humans. But there's lots of other experimental evidence out there, which in animal models and more basic science models shows how inflammation contributes to hypertension. So when we're talking about managing it, now that we kind of understand a little bit about the physiology of blood pressure regulation and the renin-angiotensin-aldosterone system, we're going to kind of piece together how each treatment would affect the kidney in a Guyton-specific or Guyton-themed approach to blood pressure regulation. So that's kind of the goal of this final part of hypertension, is to link back how each treatment refers to the initial model, both for your understanding, but also if you have essays or exam questions, it's useful to be able to base back the treatments we have now to the preclinical early science models of physiology and pathophysiology. So the goal of treatment is to reduce the risk of complication. That seems pretty obvious. And crucially, hypertension is the most important modifiable risk factor for cardiovascular disease. So if we can treat hypertension, we're doing a massive favor for reducing cardiovascular disease risk. And on the right, I've got this flow chart, which I was talking about earlier from the NICE guidelines. And it gives you a nice and easy way to remember how we treat hypertension from first-line drugs. That's more clinical. It's not super useful for preclinical. But what is useful to think about is they've divided people either into high renin or low renin individuals based on their age, ethnicity, and diabetes risk factors. And if you're someone who's high renin, essentially your primary problem is that your renin-angiotensin-aldosterone cascade is overactive for whatever reason, starting with renin at the top. So targeting that system will be beneficial. So that's those on the left. And if you're low renin, you're less likely to benefit from renin-angiotensin-aldosterone system antagonists directly. So they have a slightly different stream of treatments. Hopefully this will make sense in a second when we go through each of the treatments themselves. So first we have the RAS axis modifiers. These kind of make sense. ACE inhibitors inhibit the conversion of angiotensin 1 to 2, kind of block off the initial part of that cascade. But also because angiotensin acts as a vasoconstrictor, these treatments, or at least ACE inhibitors, reduce total peripheral resistance, TPR. Then we have CCBs, so that's the right low renin stream over here. Traditionally, or people who follow traditional models where they think, or where they would suppose that short-term and long-term blood pressure regulation is just vasotone-centric and cardiac output-centric, would say that these work just by dilating the system. But we saw earlier in the diagram how vasodilation alone does not account for a fall in blood pressure in the long term. So Guyton model enthusiasts would argue that calcium channel blockers preferentially dilate afferent arterioles in the kidney. So that means that your kidney suddenly receives more blood flow because of the vasodilation, and therefore it thinks, or it interprets that as the whole body has too much circulating fluid, and therefore stops retaining so much fluid, or stops resorbing so much fluid, increases excretion. So that's how those might work if you're a Guyton enthusiast. Thiazide diuretics, again, as with all diuretics, I always think this is the easiest to understand. They target the nephron, they change the membrane channels in the cells of the nephron, and just outright change the pressure natriuresis relationship. They just stop fluid resorption, or not stop, but massively reduce fluid resorption. I've written here just this: the kidneys can adapt to diuretics by expressing different transporters to escape action of one diuretic. So sometimes diuretics lose effectiveness over time as the body adapts to one. And this is true with a lot of these blood pressure regulation or antihypertensive medications, because the body is stuck in its way of shifting that pressure natriuresis curve up. So no matter what treatments you do to bring it down, it always wants to go back up. So you need to eventually start using combinations of different drugs if they don't work. Finally, we have beta blockers. Beta blockers, again, via non-Guyton models, would say that beta blockers just reduce cardiac inotropy and chronotropy, so stop the strength and frequency of contractions. But Guyton model supporters would say that they also work by inhibiting renin release. So sympathetic activity increases renin release, which has been on a couple of the diagrams already that you might have seen. So by blocking this, you suppress renin-angiotensin-aldosterone. And there's a bit of evidence there at the bottom. Again, more detail on that piece of evidence in the notes. But beta blocker treatment reduces renin concentrations, and they've done some studies to show that. So here I've given you two diagrams. The one on the left is just the renin-angiotensin-aldosterone cascade, and the one on the right is the whole system in general. But I thought it's useful for you guys to see where in a whole cascade or visual representation of the systems where each of the drugs act. And then here I've given you a table of all of the drugs we've already spoken about, plus a few more. And I've given you the conventional mechanism of action. So that's sort of non-Guyton model, non-kidney focused. And then on the right is the kidney focused explanation. And then importantly, this diagram on the right relates how each of the treatments alter pressure natriuresis. And again, for essays or for exam questions, it's useful to use this quick illustration to show graphically how each of the drugs work. So a couple examples. Well, I guess they all shift the curves to the right. And by shifting the curve to the right, if you think, so we take this ACE inhibitor curve here, or line, for every level of mean arterial pressure, you have a much higher level of urinary sodium excretion. So all of these drugs will shift the pressure natriuresis in favor of more excretion for a given mean arterial pressure. So that's a whistle-stop tour through the physiology and pathophysiology, and then treatments. And then in the second half, we'll talk about heart failure. And hopefully, as I say, because of the overlap in mechanisms, it will be easier to kind of piece together how treatments might work, and how the mechanism of the drug actually works. Starting with short-term cardiovascular failure, because it's in your syllabus. Short-term cardiovascular failure is referred to as shock. Again, if we think back to the role of the cardiovascular system, which is to perfuse tissues adequately or maintain a constant blood pressure, which therefore perfuses tissues. Shock is a short-term failure of this role. The signs of shock are a weak rapid pulse, that's your heart trying to keep up with the lost output. A reduced or normal mean arterial pressure, but pulse pressure is reduced. Pulse pressure is the difference between systolic and diastolic pressures. So your body might vasoconstrict in response to a short-term shock, and that moves your mean arterial pressure curves, your diastolic and systolic pressures closer together. So it means your average is roughly the same, but the pulse pressure is dropped. Yeah, and then the other symptoms of reduced urine output is a result of reduced blood flow to the kidneys. Reduced awareness is reduced blood flow to the brain. I like to think of the causes of short-term shock as each being a failure of one component of the system, and that helps me remember them slightly easier. So first we have a failure in the fluid of some sort. That's how I like to think of it. It's a reduction in the fluid. So either loss of blood through hemorrhage, loss of fluid through diarrhea or vomiting or dehydration. Burns are a massive loss of fluid because you lose your skin as a defensive layer for stopping evaporation of extracellular fluid. Cardiogenic, so that is your pump in the system failing. Fairly self-explanatory. So a heart attack, like any muscle, not receiving enough oxygen, your heart doesn't pump quite as efficiently, so there's less output. Same with arrhythmia, it's not contracting in a nice torsional way, so you get less efficient output, and so on. Obstructive, so this is the pipe lumen, so this the inner area of the pipe failing in some way. It's either a clot, like an embolus, or I guess this is obstructive in a slightly different way. Cardiac tamponade is the pericardial sac filling with fluid, so it means the heart cannot dilate enough for each stroke, so it doesn't get the positive effects of a Frank Starling curve. And then finally, distributive. So again, this is a failure of the pipes in some way, and usually it's a failure in the pipe wall. So you get too much vasodilation as a result of systemic infection. So this is classic for sepsis. You'll get a shock picture because systemic infection leads to, I guess, pathological vasodilation. It's not helpful in your body fighting the infection, and it causes a massive drop in perfusion pressures. Big emergency. So the short-term response, as per right back at the beginning, our discussion of short-term blood pressure control, is to increase sympathetic nervous system outflow. So you get your stretch receptors going haywire, feeling like suddenly there's no stretch anymore in the arteries. So you get a compensatory sympathetic outflow. Okay, so chronic heart failure is just what it sounds like. It's a chronic version whereby there is poor tissue perfusion. And crucially, I'll come back to this again later, it's an inability to maintain adequate tissue perfusion at normal filling pressures. For most people with heart failure, they are able to maintain tissue perfusion. Otherwise, they would be severely, severely unwell and on life support. But they are unable to do so at normal filling pressures. So their bodies have somehow compensated with their heart failure, to maintain tissue perfusion, but it's at abnormal filling pressures. Talk about that in a second. Why do we care about heart failure? It affects a massive proportion of the global population, and it's progressive. So without treatment, it will get worse, and people will die from it if we don't intervene. It's got a fairly high mortality rate. And usually death occurs because of hypoperfusion. So an extreme, progressive, uncompensated heart failure, your heart, your brain, and your vital organs, so your liver, etc., don't receive enough blood, and you die as a result of that. Heart failure is kind of like hypertension, like we spoke about. It's not one condition. It's really the end point of a lot of different conditions. That's probably a better way of thinking about it. It's a clinical syndrome. So that means it's a constellation of symptoms, which we can identify clinically and therefore point to as heart failure. Those symptoms are generally reduced exercise tolerance. So people not being able to walk as far. So you'll see walk tests done in clinic to see how long someone can walk before they have to sit down because their heart failure is so bad. Fatigue, again, generalized. It's kind of like exercise intolerance, but even more severe. And then you have left-sided and right-sided heart failure effects. So swelling, edema, either in your lungs or in your periphery, your ankles and feet. You have ascites, which is swelling because of excess fluid in your abdomen. So those are the symptoms that you should look out for. And if we think of heart failure as a chronic inability of the heart to maintain output, it's usually because of an intrinsic inefficiency in the heart. So it cannot do its job efficiently. If you have coronary artery disease, part of the heart muscle is either dead or severely impaired, fibrosed, so it can't contract properly. If you have abnormal rhythm, your regular torsional contraction of the heart, so the heart contracts kind of in a torsional way, is interrupted. So per contraction, you have less output, less stroke volume, so inefficiency. Valve disease, again, the inner mechanisms of the heart are not optimal. You get too much blood either flowing backwards or not flowing out at all. Anemia, I guess you kind of think the quality of the blood is worse. So for every pump of blood out, you get less oxygen within it, because you get less red blood cells or fewer red blood cells. So your heart needs to work harder to make up for that, and so on. So I thought I'd put this slide in just to talk about how heart failure is classified, because you'll hear about it spoken about in lots of different ways. And sometimes it's quite confusing because it wasn't the way you had classified heart failure. And that goes back to this idea that it's not a consistent pathological process. It's an endpoint. So when we classify heart failure, people try doing it in a number of different ways. Most commonly is by thinking about whether it's the systolic activity of the heart that's inefficient or the diastolic activity that's inefficient. We measure that by ejection fraction, which is done on echocardiography. HFrEF, you'll hear said, heart failure with reduced ejection fraction, less than 40%, is systolic impairment. So systolic failure is kind of the heart doesn't contract in that nice concentric way, either because of an arrhythmia or because the heart is fibrosed and too thick, so it doesn't quite close and squeeze all that blood out. This one kind of makes sense and is better understood more broadly, and better treatments are better able to improve HFrEF outcomes. HFpEF, heart failure with preserved ejection fraction, or relatively preserved, is a diastolic impairment. So something about the stretching of the heart is inefficient. So if we think about Frank Starling, you want good stretch to allow for increased strength of contraction. Something about that stretch is wrong. Either there's some fibrosis, so it doesn't stretch all the way, or it stretches too much. Something about that is wrong. You can talk about it either as right-sided heart failure or left-sided heart failure. That's a pretty common one based on the symptoms you see. Right-sided means your peripheral venous circulation is backed up at the point of the heart. So your heart's not able to clear enough blood through the right side, and you get peripheral swelling. Left-sided is your pulmonary circulation is not being cleared quickly enough because of the left-sided failure, and therefore you get swelling in your lungs. It's important to think, though, that if you have left-sided failure, you back up the pulmonary circulation, increase end-systolic resistance for the right side, so suddenly the right ventricle is pumping against or into a higher resistance, which leads to harder work for the right side of the heart, and therefore you get right-sided heart failure. So left can lead to right. So again, it's not a very clear distinction, because often you'll see people with both sides affected, and it's progressive. So at some point, if untreated, it will progress to both sides. Finally, you can talk about the underlying pathophysiology. Not always useful, because you could have overlapping syndromes. And then again, you'll hear talk about in terms of severity. So that's how badly does it affect the patient. So if you're thinking of a patient-centered approach, they don't care about what's happened to lead them to this heart failure point. They care about how much it affects their day-to-day. So that's why that classification exists and is useful, especially for qualitatively analyzing heart failure in patients. So if we just take a moment to think about what I said earlier, when I first spoke about heart failure, as a chronic inability of the heart to maintain adequate tissue perfusion at normal filling pressures, like key bit normal filling pressures, something about the body's way of dealing with heart failure disrupts the normal filling pressures. And we're going to show you how. So impaired contractility, whatever causes it, whatever causes the heart to be inefficient, one of the mechanisms we spoke about earlier, whatever causes it to be inefficient, means that for every end diastolic pressure, so for every amount of blood you put into the heart, compared to a normal heart, less blood will be pumped out. So the stroke volume is the output, end diastolic is the input. That's how I think about it. So for every input in a failing heart, the output is worse. But the body compensates for this by pushing you up along this curve. So you don't just drop straight down to a worse stroke volume. You need the same stroke volume. Your organs still need the same blood supply, but they need it from a worse performing heart. So the way your body gets around this, or a failing heart would get around this, is by first increasing sympathetic nervous system activity. So more pumping of the heart, harder pumping of the heart, and more vasoconstriction to get your blood to where it needs to be faster. Your kidneys respond by upping your plasma volume. This is essentially, if you think about like the kidneys, I keep saying feel like, but they interpret this failing heart as not receiving enough blood themselves, and therefore respond by increasing the amount of fluid circulating to bump up that blood pressure. Over time, both of these effects, so this fluid loading means that your heart's dealing with more fluid every contraction, leads to cardiac hypertrophy. And at first this is good. You get productive hypertrophy of the heart, but eventually this becomes pathological. And you hear a bit about concentric versus eccentric hypertrophy. Maybe in third year you'll hear about that stuff, but it's thrown a bit around as like, if you have someone who does a lot of exercise, they'll have physiological hypertrophy. Someone with heart failure will have pathophysiological, pathological hypertrophy. It's not helpful. It doesn't help the heart contract better. It means that the walls are too thick, they don't squeeze out enough, or the walls are too stretched, and they don't have the strength to contract all the way in. So you kind of have two streams, but both are pathological hypertrophy. And finally, vasoconstriction across the whole body will also help bump your blood pressure up and save this failing heart. Over time, this is kind of a positive feedback cycle. Your fluid overloading and heart hypertrophy are good in the short term, and then make your heart less efficient over time. Less efficient heart over time means they need more sympathetic activity and more fluid overloading, and you get this positive feedback loop of worsening heart function. So the diagram on the right shows someone who's in compensated heart failure. So they're able to reach the same stroke volume as a normal heart through these compensatory mechanisms. And at exercise, they're even able to reach the same stroke volume as a normal heart. But if you imagine over time, this failing left ventricle curve shifts further and further down to the right as it gets more inefficient, you'll get to the point where suddenly they can't achieve the same stroke volume output at exercise. So they might get breathless whilst going for a run. Or you shift it far enough down and then they can't achieve the same stroke volume for walking. They get breathless walking. Eventually, you get so bad that even at rest, your stroke volume is unable to keep up with a normal heart. This is kind of what you refer to as uncompensated heart failure. The body cannot achieve a normal tissue perfusion at rest. And this is where it gets really dangerous, because you get people admitted for, even while sitting, they cannot achieve normal perfusion pressures because their heart is so maladapted. We thought a lot so far about the negative compensatory mechanisms of the renin-angiotensin-aldosterone system on the right here, and how this might contribute to the positive feedback loop. But your body also has a counteracting system of natriuretic peptides. So ANP and BNP are released in response to right atrial stretch, which happens with fluid overload, increased end diastolic volume, all these things that happen in heart failure. These are released and they endogenously, so they're produced by the body, in the body, antagonize the renin-angiotensin-aldosterone cascade. And this endogenous antagonism is great for people who are healthy and early stages of heart failure, because it kind of keeps the heart failure response in check. But over time, it's insufficient to stop heart failure from progressing. But if we think about what we would want to achieve when treating someone with heart failure, it suddenly becomes another avenue of treatment. You can block the pathological response on the right, and you can upregulate the response on the left. So in terms of treatment, it's a really helpful cascade to be aware of. So now that leads us nicely on to think about treatment. On the right here, I think, is a really excellent diagram of a couple of the processes I've talked about so far. So in heart failure, reduced efficiency of the heart, you get reduced cardiac output. What does that do? You get increased sympathetic activation, increased vasoconstriction, increased renin-angiotensin-aldosterone activation, increased cardiac filling pressure because of the increased retention of fluids, and you get remodeling. And overlaying this diagram are all the treatments that we have, or some of the treatments we have, sorry, to counteract heart failure. So first, like we were talking about earlier, ACE inhibitors and aldosterone receptor antagonists. I won't talk about them again, but we know that those will block off the renin-angiotensin-aldosterone system and therefore stop that fluid overloading that's happening. We know now that ANP and BNP are beneficial, so we want to keep those as high as possible in the body. So neprilysin is the endogenous enzyme which degrades ANP and BNP. So we inhibit that with sacubitril and valsartan. Sorry, sacubitril. Valsartan is an angiotensin receptor blocker. And this trial here, the Paragon heart failure trial, is just some good evidence for how successful neprilysin inhibitors are. I've put a list of trials in the notes section for this of which kind of give evidence for how successful some of these treatments are compared to each other. I think that's really useful to have if you want to write an essay on these topics in exams. It's always useful to have a piece of evidence backing up their effectiveness after you've spoken about their mechanism. And if you look in the textbook often referred to by Patterson in his lectures, the Levick's cardiology, there's a great diagram or great table in there that has all the studies you should be aware of if you want to talk about these drugs. So continuing on, we have beta blockers. You see how those might help, blocking renin secretion, also reducing the work of the heart, stopping it contracting so hard and so much, whilst you address other aspects of your heart failure pathophysiology. Diuretics, they stop the fluid overloading, stop that end diastolic volume, stressing out your heart. And vasodilation, again, you reduce the end systolic resistance in your arterial system, and you reduce the work that the heart has to do to get that blood out against the system. But if you think about what all of these treatments do, they're all undoing the compensation, which I spoke about 2 slides ago. All of these treatments undo the compensation to try and put a stop in that positive feedback cycle. But the reason you have that positive feedback cycle and that compensation is because your body is trying to make up for that lost cardiac efficiency. So if you really want to treat heart failure, you need to get down to the reduced cardiac efficiency. All of these treatments are just kind of targeting the symptoms, and they're targeting the end loop that you get. They're not targeting the root cause of the heart failure. So treatments we have available to treat the root cause are largely involved with improving contractility and changing remodeling. So opposing the pathological remodeling that goes on in a failing heart. So first, contractility. Inotropy, as we said at the beginning, is the force of each contraction. Drugs like digoxin, omecamtiv, and dobutamine basically mean that per contraction of the heart, for the exact same number of contractions, there is increased stroke volume. So the heart's able to extract more contractile force for a given amount of ATP. So they're really, really valuable drugs, and they really get to the core of the heart failure cycle. If you think about things like ICDs and anti-dysrhythmics, that's again getting to the core cause of the problem. If your heart's inefficient because it's arrhythmic and not contracting properly, it's fibrillating, or it's not having a smooth cycle of contraction, by improving the synchronicity of the heart, you can extract more output for less work, getting to the root cause of cardiac inefficiency. And then positive remodeling. All of these drugs here, SGLT2 inhibitors, we haven't spoken about yet, but I'll talk about in the next few slides. ACE inhibitors and angiotensin receptor blockers have additional positive remodeling effects. And spironolactone. All of these stop the heart from becoming fibrosed, thickened, and inefficient, and therefore give the heart a chance to come out of that positive feedback loop. And something which you might study in 3rd year if you choose to in the advanced physiology and pharmacology is about the cellular, metabolic, and structural effects of heart failure. And drugs like these really antagonize the intracellular mechanisms that are going on in heart failure and improve the heart from the ground up. So I've summarized here on this slide probably the core approaches to treating heart failure, which you would want to achieve if you were treating someone. And that's treating the underlying cause, like we talked about. So if there's arrhythmias, get rid of those. Improve the efficiency of the heart in that way. Reducing the cardiac dilation and fluid overload that you're experiencing through RAS activation. You want to reduce the afterload. So change how much work the heart is having to do to put fluid out into the system. You want to improve the cardiac contractility, which we spoke about right at the end, making it more efficient. And you want to reduce the work that the heart has to do. And that's once you've resolved the cardiac efficiency, you want to make it work less hard. You can't really do this until you have improved the efficiency, because if you're just making the heartbeat slower, yes, you're saving the heart from the pathological feedback loop, but you're still leaving someone slightly uncompensated. So you would want to improve cardiac contractility as well. This slide kind of gives you an idea of how combinations of heart failure drugs are worth more together than they are alone. On the left, you can see how introducing each of the different types of drugs reconstructs or partially reconstructs a normal Frank-Starling curve. So you start at this red dot here. You might add an inotrope, so more efficiency, moves the whole curve up. So for every end diastolic volume, your stroke volume is better. You might vasodilate, which reduces the end systolic resistance. So the heart's not working against such hard resistance. And so again, you shift the curve up one more time. And then finally, diuretics. You move yourself down the end diastolic volume. You excrete much more fluid, and you stop fluid overloading the heart. So again, you've moved yourself up much closer to a normal heart's curve through a combination of treatment. And the review on the right is just useful as a solid piece of evidence, which basically says that modern trials have shown, if you look at them en masse, that this combination of 4 drugs is the most effective treatment selection we have available to reverse HFrEF. So it basically argues that we should be treating everyone with heart failure with HFrEF, so reduced ejection heart failure, with this combination. Kind of like on this diagram on the left, it really salvages a failing heart. Just in the last few minutes, I want to talk about some sort of novel drugs, which are A, interesting, but B, useful if you want to put some extra points in your exam essays. First, we have SGLT2 inhibitors. Now, these were first introduced for diabetes because they block glucose resorption in the kidney and allow you to excrete more glucose through urine. But they were also then shown to be effective in reducing cardiovascular morbidity and mortality in HFrEF. And they were even effective in the absence of diabetes. So right here at the bottom right, they have positive effects indicated by the hazard ratio at reducing cardiovascular morbidity and mortality, despite or in spite of any diabetic any diabetes being present. So clearly there must be some additional mechanism that isn't just acting as the nephron, which explains how these work. And so I'll explain that to you now. Some research basically showed that firstly, that SGLT2 inhibitors weakly inhibit SGLT1 as well. And that's what this top diagram is showing. So this is a IC50 number for each of these drugs, which basically shows it's the half maximal inhibitory concentration. So how much of each drug is needed to inhibit a receptor. And there's a small number for SGLT1, at least on all of these, and some bigger than others. So basically they all work across both receptors. And the SGLT1 is expressed in the heart. So this diagram here in this paper shows expression of this receptor in the heart. And then in these diagrams here, you basically show that the idea is that SGLT1 receptors are involved with oxidative stress within the heart through some oxidative stress cascade, which involves NADPH oxidase, which you will have heard about in your inflammation and infection lectures. This paper basically shows that by increasing your concentration or increasing your concentration of SGLT1 inhibitors whilst incubating myocardial cells with NADPH oxidase activators, you get a reduced production of superoxide, which is a reactive oxygen species. Again, more details for this in the description of this slide, but it's just evidence to show that they think the reason why SGLT1 inhibitors work on heart failure is by altering the intracellular reactive oxygen species cascade. This goes back to this idea that what I've spoken about today is mostly the whole body picture of heart failure, but a lot of the pathophysiology starts within the cardiomyocytes with their metabolics and their ultrastructure. And so SGLT1 inhibitors might work by improving the inflammation at a cellular level. To close on, I thought I'd just give you my two interesting points which I've learned in the last year and would be worth maybe reading about, writing about in an essay, thinking about as you come to FHS research in the future of heart failure. So first off, we have this thing called the obesity paradox. So the idea goes that people who are overweight or obese are more likely to develop heart failure. So you might tell them to lose weight before they develop heart failure. But once you have established heart failure, they found that those with higher BMIs have better survival outcomes. So you suddenly think, can I tell them to lose weight? Or is that actually going to worsen their outcomes? And we don't actually have a clear answer to that right now. So that's one interesting point. And that ties into the second interesting point, which is that GLP-1 agonists are having a massive breakthrough at the moment. People are using them not only for diabetes treatment, but also for weight loss. And they are extremely popular in the US. You might have heard of them, Wegovy, I think is what it's called to. It was referred to as. But there's a bit of controversy as to whether or not we could use them in heart failure because of this obesity paradox we mentioned before. So this review by Khan et al. Kind of goes through all the available evidence we have and surmises that there's not a clear benefit to be found for using GLP-1 agonists in heart failure as of yet, and despite what some of these companies who produce the GLP-1 agonists would have you believe. So there's definitely room for research in the future, sort of understanding this relationship a little bit better. So that's everything I had to say on these topics. I know it's been a lot all at once, but my hope is that it's been a good base to build on. And the slides, as I said, have much more information in the notes if you would like to see those. And yeah, if you have any questions, I'll stick around for a while.